I'd like to thank Dr. Hoyt on behalf of the SAGES, the AAST, the SSAT, and ASCRS for accepting our invitation to come and speak during this session today. A man who certainly needs no introduction, Dr. Hoyt has a long history of surgical leadership in the United States, including being the trauma surgical director and the Monroe Trout Professor at UCSD before transitioning to the chair of the Department of Surgery, the John Connolly Professor, and the Executive Vice Dean at the University of California, Irvine. For almost a decade, Dr. Hoyt has served as the Executive Director of the American College of Surgeons. He's championed the development of multiple verification programs. I've had the pleasure over almost the last year of joy and honor of working with him on the American College of Surgeons EGS work group. It's been a pleasure watching him lead and learning from him and the other thought leaders in the work group. His unwavering commitment to surgical quality and improvement of patient care is an inspiration. Thank you, Dr. Hoyt, for joining us today and sharing your perspectives.
Well, good afternoon, and thanks for the invitation. It's been a real pleasure for me to be able to work with many of you on this new project. And first of all, congratulations on this course. I've been able to listen to the first couple of sessions, and I think it's been a great course. So we need more of this. And what I'm going to try and do is show you how I think this is going to fit into where medicine's going and where emergency general surgery is going. And I'm going to frame it with really our primary responsibility to our patients, and then how we look at this through our eyes as surgeons, which is different from the way the payers are looking at this, different from the way internists look at this, and it really is an important perspective that we really need to have a voice so that we can do right on behalf of our patients. So many of the programs we develop is to try and represent this responsibility through our eyes. Now, you all know the college's emblem, and at the bottom there it says in Latin, it says to serve all with skill and fidelity. And if we're going to make good on that promise, we are aspirational in serving all. And I think our commitment through many of the things we do as SAGES or as American College of Surgeons is to bring our best practice ability, our skills to the patient. So this is a journey. We're not there yet, and I'm going to try and show you some of the programs we're developing and where emergency general surgery fits into that. Now, another way to look at this is professional responsibility can run the spectrum from that to an individual patient, and I think every one of you here lives with that every day. We do have some work to do on access to care, if we're really honest. It's one of the biggest criticisms you can make of the U.S. healthcare delivery system. And we've got to figure out the socioeconomic effects because it's actually undermining our economy to some extent. The more global issues that you can think of as professional responsibility, we have certainly presence in. But what I want to do is spend time talking about these first three programs from a programmatic standpoint as this part of our professional responsibility. Now, if you look at the heritage of the college, and I think you all know this pretty well, it goes back about 100 years. It started with a meeting like SAGES, showing each other how we do things, having discussions about the debate of how to do things. And we've done that very, very well. What came up during those initial meetings was we needed to educate the next generation. And the next generation had no formal residency training at the time. There were just the beginnings of what things we would call residencies. There were no boards at the time. And there was even tremendous variability within hospitals. So the first thing people did was focus on standards for hospitals. So the principles of standards for hospitals actually started within the American College of Surgeons, the original history and physical that we've all been brought up on for the last 100 years were written in the American College of Surgeons. And that organization actually became what we now know as the Joint Commission. So for the first 50 years of what is now the Joint Commission, that was work being done by surgeons on behalf of their patients. Building on that tradition, we have now developed programs in cancer, trauma, bariatrics, et cetera, and we're in the middle of starting to build a program for emergency general surgery. And the collaboration we've had from SAGES and the AAST and many of the other people that are involved is really to try and bring to this field an organizational structure that will add to the intellectual content that you all are very involved in. Now, as you come forward, we have developed a set of principles for a quality infrastructure program. And these are our principles, and I say our principles because this is how, when we start a new program, such as we're doing with emergency general surgery now, we're doing one in high-end GI surgery, so hepatobiliary, pancreatic, and hepatic. We're doing one in vascular in combination with the SVS. We're doing one in thoracic with STS. As we develop these new programs, everybody has an opinion about how to do it, and what we've settled on is this model, at least as the way to get people organized and started. And you start by getting a group together, coming to consensus around the standards of resources that are needed, both personnel, equipment, the kinds of conditions you're going to care for, what is needed and essential, so that there's no debate when you start to set up a program. The debate occurs in setting the standards, and we use evidence when it's available or consensus when it's not. But that standard-setting function has occurred in every one of our programs. The next thing is you build out the infrastructure to support that. In a hospital or in trauma, for instance, you go into the street. So you have to have an EMS system, et cetera. And depending on what you're building, that's determined what the infrastructure is needed. The third is to create, ultimately, the desire is to have consistency in care. You all want that in your practice. You want that for your patients. That's the way you practice every day. And the only way to really get there is to have data to inform you objectively so you can find areas to improve, and I'll show you why that's so important going forward. So the implication for us is to build a data system to support a set of standards so we can move toward this concept of high reliability. And then finally, if you really think you've got something good, you should be willing to have it peer-reviewed or verified. And so, accreditation is always brings on the concept of regulation, et cetera. But if we self-impose through verification, peer review of our programs, then we can really stand up to the public and say we're delivering what we say we're delivering. Now, here's an example. I'm a little biased about this because I was very involved in the development of trauma systems over the last 40 years. But if you apply those standards, what this did is it created paramedic training, regionalized EMS systems, access through 911, et cetera. It created language, ATLS, to talk about how do you manage the care of the patient initially. It created trauma care standards for hospitals, what equipment, what personnel you need available. It created a verification program, and it created a database to measure performance. So I would argue that this is not a bad model to think about healthcare delivery for the entire population for every disease. It is population-based, it is payer-blind, and it goes according to a formula. Now, does it work? Here's some data from San Diego when I was there 35 years ago. It's hard to believe. This is before a system. And so you had a no system, and when you measure preventable deaths, which there's definitions for, and there's a whole nomenclature for that, they were reasonably high when we put the system in place, and then remeasured a year later, they had dropped down significantly. And then when you measure that performance over time, you get the same kind of sustained result. You can look at the complications, you can look at anything you want, and you get this effect when you basically pay attention to a problem. If you look at that number across trauma systems, as they have all been built up around this country, on average, it leads to about an 8 to 10% mortality reduction. That's real. The data exists, that's real. Let's go to a different example that's perhaps a little closer to home in terms of being a commonly done general surgery procedure. Here's bariatric surgery. You go back 15 years, the mortality of bariatric surgery done with inconsistent practice by pretty much anybody that wanted to do it, by mostly open procedures at the time, et cetera, was somewhere around 4 to 6 per thousand. You add a non-invasive way to do that. You train people how to do that. You create standards for centers and all the resources that are needed to do that, and the mortality comes down. And now bariatric surgery is somewhere between esophageal reflux surgery and appendectomy in terms of mortality. That's an incredible thing if you think about that. This is not gene therapy. This is not inventing a new antibiotic. This is simply doctors working at a problem and slowly getting it better. So this is the model that we're using to go forward in addition to the great things that happen in research and new innovation. Now, I'm sorry that this slide corrupted, and we thought we had it fixed, but obviously not. It's a PDF, so it just something happened. But what this shows is all the programs the college has developed and is in the process of developing. But if you think about it, you know most of them. There's trauma, there's cancer, there's breast cancer, there's colorectal, there's bariatrics, there's a children's surgery program. We're in the process of developing emergency general surgery, thoracic, vascular, complex GI, and in addition, we have a geriatrics program that's just being launched this summer. We have Strong for Surgery. We have a number of programs that take a disease or a piece of disease and get very focused and then come to agreement. And what's not shown on this slide is we have a database to measure performance for each of those so that the people creating the unit can actually improve. Now, Cliff Coe and I sat back about 4 years ago and said, you know, we've got a lot of things that are common to these programs, and the trauma surgeons created trauma, bariatric surgeons created bariatrics, but they were actually coming up with very similar things in terms of the infrastructure that needed to be put in place. So we started a project that actually ended up being reorganized and rewritten twice before we released it. But just about 2 years ago this summer, we released what's called the Red Book. And in the Red Book, what we define are what the optimal resources for surgical quality and safety are. This is not to tell you when to put antibiotics or give antibiotics or whether if you put a stent, when to time the definitive operation. What this talks about is the structure you need in a hospital to oversee care, find your problems, fix your problems when you have it, again, moving as a system of care to high reliability. So it's from this we came up with this concept of the 5 phases of care. You all know how that is, when I was trained as a resident, the patient was mine forever. We've replaced a lot of that with teams, which is good, but we've got gaps in teams, okay? There were several conversations this morning about people staying involved, okay? So what the 5 phases of care tries to define is what our responsibility as surgeons is across preoperative assessment, appropriateness, immediate preoperative assessment, intraoperative elements, postoperative care, and yeah, if you put a patient in the ICU, that may be managed by a team, but how do you stay involved? And then finally, post-discharge and long-term follow-up. It dives into every major disease category in surgery, et cetera. But now that these standards have done, we've created a set of expectations to look for in a hospital, and we now have a verification program just for the Red Book. And we think what we're going to be able to offer going forward is if you want to be a cancer center and a trauma center, is to actually bundle these together so that people can get multiple verification criteria. But this has taught us a lot in putting this together, and it's really gotten the attention of some other people as well. Now, this is just one example. If you haven't read this book, I would recommend everybody get a copy, have it on your bookshelf, and at least read the first 9 chapters. That's sort of the Cliff Notes version, okay? But when you talk about preoperative care, if I ran down this list, you'd all say, oh, yeah, sure, we do that. But we know that these things are not being done consistently, particularly amongst some of the surgical specialties or subspecialties. So having appropriateness criteria, having a identifiable risk factor that you can modify to optimize care, having a risk calculator so you can have an informed patient discussion. These are all increasingly very possible things, and so we're basically setting out that these should be done. Informed consent, still a lot of variability around that, and if we don't take leadership of this, what's going to happen is the Senate Health Finance Committee is going to tell us how it's going to be done. It's just that simple. So we really have to step up into these areas and offer what I know we can do better than anybody else. Here's immediate pre-op phase. This is the site marking. This is the redosing antibiotics. This is what do you do with the insulin or whatever. So all this is detailed, and the whole point of this is that if we can create this, then we can create a measurement tool to increase our performance. Now, as you look across all of these programs, all of the standards that have been developed over really almost 45 years at different times for different diseases fall into these 9 basic categories. So what we're doing is we're rewriting all the books to be conformed to this format, and then try and, again, give a overall brand so that if you're a member of a hospital that's participating in this, we believe we can ultimately link this to preserving payment for physicians and payment for hospitals as well. Now, does that work? I mean, I showed you some trauma data. I showed you some bariatric data. This is generic general surgery, okay? So if you take NSQIP and you put that tool in your hospital, and you measure performance, that graph in the upper left is a caterpillar graph, and that line about a third way up would be considered average. And when you array against a complication, some kind of process there, anything you want, this is what the distribution looks like. And on the right in red are people that are performing less well than expected, and in the green on the left are people that are performing better than expected. When you do that and you show this data transparently, we're surgeons. If you're in the red, you go to the green people and say, what are you doing that I can do so I get over in the green? We're competitive. And that's exactly what happens. When we studied this 150 hospitals, over time they reduced complications by 82%, mortality by 66%, and it's a believable number. It's about 1 complication a day for a 400-bed hospital. You do the math on that, and now you've got the government's attention, because that adds up to, in this case, somewhere between $25 and $35 billion if you had that effect, just from this alone in terms of improving care. The other thing that we've learned is meetings like you're having here today, or having interdisciplinary collaborative discussions using data improves care. And this has caught on. It's almost replacing some of the chapter activities that the college has done. There's an Illinois collaborative, for instance, next week or sometime in the near future. And they have hospitals from all over the state coming together to talk about surgical care. So this is an essential element. Data and collaboratives are essential components of this quality. So if you put all this stuff together into a funnel or to this could be, I guess, a martini glass, and stir it, what you have is, starting with standards, you set the standards, you build out the infrastructure to support that, you get data to inform performance, you add collaboratives, you add guidelines, you add education, and you couple that with verification. This is how we are defining quality today in American medicine. Okay, now can we do it better? Well, it turns out the group at Harvard Business School have been looking at this for about 15, 20 years. And Michael Porter, who you've heard the name, if you haven't read this book, it'll put you to sleep at night. But you can, again, you can just flip through the diagrams and get the message. What Porter's group has been saying for 15 years is identical to what the college is saying. And that is what you do if you want to improve quality, if you want to move to true value-based care, which we all talk about. This is the formula. You create what he calls an integrated practice unit. Well, that's a cancer center or a trauma center or a bariatric unit where you define the resources, you bring them together, you exercise that team, and you deliver bariatric surgery, whatever. You measure outcomes as a part of that performance. That's what gets you better. What you think's going on, if the data doesn't support it, gives you an opportunity to get better. Now, the one thing that we have not done historically is measure costs. And that's something we need to add. It would allow us to move into a value-based or at-risk model for healthcare delivery, bundled payment, and you may not want to see us go that direction, but that is the direction things are going. So again, we need to be prepared to do this correctly. So if we took our model and added this risk-adjusted cost, then we actually would have an even better thing to not just talk about quality, but to actually articulate value in a much more precise way. So how you do the cost piece, this is a complicated slide, but this is an elective procedure. It's simply mapped through using a methodology that's very common to multiple industries, and this is now being adapted to medicine. It's basically called time-based cost accounting, and you lay out all the steps, and then you assign a price to each step, and you roll it up. And this is something the college is going to get very deep into. And to do that, we have been looking for partners. Now, here is an example of what you could do. I showed you the array of complications and how you would use that to improve your practice if you saw your infection rate was high. What if you had costs the same way? Say this is 100 colectomies, and the average price that you're estimating is $19,900, and you want to know how do we do on that in our last 100 colectomies. Well, now you can do that. You can array them. You can get cost analysis. The greens you're making money on. The reds you're losing money on. So you're going to put your efforts on looking at the reds and figuring out what you can do to improve. This is going to be essential if you're going to go into a at-risk environment as well. So quality and cost are going to be value, and we've got to have the tools to support our practices. Now, as I mentioned with the Red Book, we're starting a verification program, and we're already seeing a fair amount of high variability. So this is going to be a valuable exercise over the next 5 to 10 years. It's going to take culture and leadership, and those of you that are interested in emergency general surgery, this is going to be a critical thing to do. We've already got some people that are helping with that leadership. You're going to own this. I'm going to be at the beach, okay? So it's the generation in this room that's going to own this, and this is a tremendous opportunity for you to get in on the ground level of the new program. We're, again, headed toward high reliability, and I won't dwell on that anymore. Now, just one other thing to pique your interest is we've been talking about digital environments for 30 years. We have the EMR. They're not working. We all know about all those stressors and so-called pajama time and all that stuff. Let's put that aside. It needs to be fixed. But let's think about the enabling ability of a digital world in which you could have patient care be your focus and have the digital world keep up with you, track all your outcomes so you don't have to do that, allow you to be reminded with new evidence. If you're taking care of cancer patients, find out what the clinical trials in your area are instantaneously when you're seeing a patient. All that is technically available today, and what we've got to try and do is build it. And again, the college is really trying to lead that. Now, I said we were looking for partners in this, and when you get into the cost thing, but also delivering high quality, it turns out that the Harvard Business School group, under Michael Porter's leadership, but there's about 15 or 20 of them that are very engaged in this project, have realized that what we're doing in the college is symbiotic. And so Things that contribute to that is that we both believe that the best outcomes and lowest costs are important, that physicians need to be part of the leadership, care should be organized around a condition, et cetera, et cetera. So what we've done is we've fostered a partnership with the Harvard Business School. We'll be announcing this in the near future. But what it really gives us is an opportunity to go from what we've been doing to hopefully a higher level of care. And this, again, corrupted, but basically at the bottom there is a model that shows the difference between what we'll call conformance quality or true quality improvement toward luxury quality or highest quality. Conformance quality is sort of like this, okay? If you, anybody here have a Pinto? You're too young, okay. How about a Yugo? Nope. Okay, everybody's got. Anyway, there used to be Pintos around, and they were highly unreliable. They would burn up, et cetera. So how do you get a Pinto to a Toyota? Okay. How do you get a car, generic car that doesn't function very well, to a Honda? And the manufacturing industry would say that you do conformance quality. So you standardize things, you manufacture to the same level. Much of what we've done in the quality movement in medicine in the last several years has been based on Duran's teachings. Duran took a model of medicine, he moved it to Japan. Japan copied the American automobile industry. They taught that at the Chicago Business School for the last 40 years. And that model is really conformance quality. You can get a lot better. Trauma centers in this country today are conformance quality. Bariatric centers today are conformance quality. Now, if you want to go and shift to the right and actually improve your outcome performance from conformance quality, you now need data. You need data constantly to modify and make incremental increases. And this is how you get to Mercedes or BMW or Lexus or Acura. Now, there are luxury things out there like Jaguars or Rolls-Royces. The problem with them is they're really good when they work, but when they don't work, they lose points for that. So this model, it's not perfect, sits pretty well with what we're trying to do. So we're trying to take our programs that get us better through conformance and actually figure out how to augment them. And many of the things you talked about today, particularly the last session about patient-reported outcomes, that's going to be the secret sauce. So to do that, you need a set of ways to get data to inform what you're doing. And we've had structural measures for 50 years. We've had process metrics for 50 years. What's new is going to be things about accuracy around safety, accuracy around patient-reported outcomes, et cetera. So this is where the investment's going to be, and they have to be risk-adjusted. But that's, again, the future of making what we offer to patients better and better. And we're going to have to partnership with the payers. So this project is really going to try and take all this stuff and take it to the next level. Now, that arrow is supposed to be pointing to emergency general surgery. So I'll just end to show you the groundwork we're laying. And again, we've had great help from members of your organization in doing this. The emergency general surgery program scope is going to cover at least these diseases. And the idea is that a emergency general surgery service, that doesn't mean an isolated unit, that doesn't mean people that only do that. It means that when you have a set of service standards that you will conform for certain things in your hospital, will assure a standardized, consistent care process that's multidisciplinary. So take GI bleeding. You may be in a place that has a great approach to GI bleeding. Many places don't. They have a highly variable one. It's going to need leadership, and we've defined what the leaders of this program would be. Again, this is not FTEs. This is more functions. So you need a surgeon leader, you need a program manager, you need data extractors, and you need people to be able to do quality improvement. You need a team. Okay, and that team has to have some committee oversight responsibility. And on that team, you need the players that are going to be involved in this program. So you need emergency medicine, anesthesia, critical care, radiology, all these kinds of things. And what this committee or these sets of committees do is they provide administrative operational oversight. So when you need to develop a protocol, when you have a problem that needs to be solved, you've got a place for that to go. It'll conduct retrospective case review to see how you're doing. It'll look at data systems through a registry or other options. And then it's responsible also for peer review. So if you've got somebody that's out of bounds or needs help, you're going to identify that and you're going to have a way to fix that. Now, for the resources, the document's going to define availability of surgeons for these kinds of diseases. It's going to have the same expectation for appropriate consultation for emergency general surgery. It's going to define the availability of anesthesia services. And many of you are probably in academic medical centers where this is not an issue. But a community hospital of 200 serving a population city of 250,000, this can be a highly variable experience. So we're trying to help standardize that. And we've even talked about how quickly an operating room team has to be available. Think of a VA hospital. I know when I practiced at a VA hospital years ago, this was always a debate on a weekend or after 3 o'clock. Specialty services, who might you need to call, and how would this group be available either in person or by phone call, et cetera. What are the other resources that are essential for your patients? And you already talked about some of those this morning, palliative care, et cetera. How do you make those things available for these patients as part of a program? What if you don't have the resources locally? How do you identify the patient that needs to be transferred? How do you work with the receiving hospitals at the other end to actually make that happen? And it lists some conditions that may be the criteria by which people start to do that. What are the qualifications of a EGS surgeon? And you all are doing a panel this afternoon that involves 4 different societies. All of them are part of it. So it really defines the basics in terms of training and credentialing, but then it's really going to be the commitment to the program, irrespective of how you were originally trained. It talks about how do you introduce new technology. And I went through laparoscopic cholecystectomy being introduced 25 years ago, and I remember vividly how that was brought in, and we can do it better, okay? So how do you create a formalized curriculum for new technology? How do you create proctoring that's appropriate and expert? And how do you introduce outcomes monitoring? That's work. In fact, I met with your leadership this morning, and we talked about these very things. How can we collaborate to do that? Our partners that may have a little different sensitivity to these patients or may throw data at you versus what you want to provide services. We talked a little bit about this with the stenting, but there's a trend to say that GI bleeding can wait, okay? And or interventional radiology drainage of an abscess can wait. And if it's Friday afternoon at 6 o'clock, it may be Monday morning. Well, any of us that were trained as surgeons, we don't agree with that. So this is going to actually hold a medical staff to a standard that we're coming to agreement over. How do you do case review to make sure that you're catching your problems? And that's partly through a registry, but there's lots of other techniques. How do you do individual peer review? And in particular, how do you do that when you've got somebody that's having problems? Because nobody has a good answer for that, but it's a solvable problem, and you can either help that person redirect their practice, or you can get them the skills that they need to improve. And I'll tell you, the group that does this as well as anybody is the military. We've defined what the data surveillance systems are, and we're working on trying to get a solution. In the interest of time, I won't go into that. And then how do you do data review using your committee infrastructure to do this? Now, this may seem pretty far away from actual clinical care details, but these are the things that lead to those improvements we saw with bariatric surgery, et cetera. So having this kind of operationalized devotion to quality and safety around emergency general surgery will be to the benefit of our patients. And then how do you do the fix? You need resources, and the hospitals have got to invest in this as an appropriate investment in the time that you all as surgeons are going to take to lead this. Now, we do have partners in this, and we've alluded to this. The AAST, which is the trauma organization that's academic. The college has several advisory councils involved. SAGES, we've had really, really great representation for that, and I think they represent our future. And we've had SSAT. We're reaching out to the endoscopic societies and the other groups that we have to have conformance with. So this is a work in progress, but this is a team effort. Just to wrap up, the surgeon of the future, I think, is going to increasingly lead a high-performance team. That's many of what you all do now. Think of emergency general surgery. That's really a team sport today. We're all going to be parts of systems of care. We're going to have to be transparent about evidence basis. We're going to be held to public reporting at some point. And the quicker we can get to that with data we're comfortable with, the better. And we've got to have continuous professional development. So the structures I've been talking about is really how you try and accomplish these things. In many ways, we're redefining our sense of professionalism. And we're moving from a time when we did things by autonomy and authority, and we said, please do it the way I say, to now really being more collaborative and being held to evidence and measurement. So to me, it's really a redefinition of us moving toward accountability. And with that, I'll just end with a very brief video that kind of tries to summarize this, and hope you'll find this useful. Turn the sound up, please. Again, thanks for the opportunity to be with you today.